Hi, everyone. Welcome to NYEMSC's Social Emergency Medicine Advocacy event. I just wanted to explain what NYEMSC does a little bit more. We are a student-run organization throughout the New York State that hosts emergency medicine events to help educate and encourage medical students to participate and get involved in emergency medicine and possibly pursue it as their career. I'm joined here tonight with my social media coordinator, Rebka, and I'm acting vice chair this year. It's a pleasure for us to be hosting this event. I also wanted to note that we have a lot of events happening throughout the year apart from this. Going forward, we are planning to have a VSLO and kind of a sub-I rotation event sometime in February, and then we also are planning to have a critical care event as well. So you can follow us here on our Instagram or Twitter to get any kind of updates. I'm going to pass it along to Rebka to get us started.
Thanks so much. Hi, everyone. Again, my name is Rebka. I'm the social media coordinator of NYEMSC this year. Thank you so much for joining us tonight. We're going to have a really amazing discussion with a great panelist. And we hope that you all join in and offer some questions either in the chat, or we'll also have some time for questions at the end. But to get us started, I'll first introduce our panelists. We have Dr. David of South Shore University Hospital and Northwell Health, Dr. Jameson of St. Barnabas Hospital, Dr. Arecochea of SUNY Downstate Kings County, and Professor B of Columbia University and an independent consultant. Thank you all so much again for joining us. So we'll go ahead and start with our first part of the panel, which will be about advocacy in emergency medicine. And our first question is for all of our panelists. Please share more about your position, connections to social emergency medicine, and current social EM related initiatives.
And I think we're just going to go around robin, whoever wants to start, and then we can just go from there.
I can speak a little bit. Hey, everyone. Thank you all for being here. My name is Adrian Arecochea. And among other things I do with my life, I serve as director of social emergency medicine division at SUNY Downstate and Kings County Hospital, both for the residency program and for the emergency departments. I took part in the social emergency medicine mini fellowship that the residency program has when I was a resident at this program. And currently we're working to get better social determinants of health screening at both Kings County Hospital, which is a city-run hospital, and then also University Hospital at Downstate, which is a state-run hospital where we work. We help admitted patients with absentee voting when they're admitted to the hospital and it's election day. We're working to get emergency room patients and outpatient clinic patients access to a food pantry based on a successful pilot that we ran out of the emergency department. We have social emergency medicine and advocacy day for every new intern class to introduce them to the concept of emergency medicine and advocacy. And we walk around the neighborhood where our patients walk and visit local community-based organizations. And I'm also involved in some graduate medical education research and interventions. One is aimed at residents who are struggling in their residency programs because of sociocultural factors and other issues. So that's a coaching program that I'm helping to evaluate. And then another thing I'm involved in is aiming to identify what is causing dissatisfaction and unacceptability of services for our patients so that we can teach residents of all specialties how to make our hospitals and clinics a more welcoming and culturally accessible place for our patients.
Okay, I'll jump in next. As was mentioned, my name is Dr. Sarah Jameson. I'm an emergency medicine physician at St. Barnabas Hospital in the Bronx, where I serve as the chair of our Diversity and Inclusion Committee. I'm also the founder and the director of the Summer Enrichment and Mentorship Program, as well as the Science, Technology, and Medicine pipeline programs. They're both pipeline programs that aim to increase the amount of Black and Brown healthcare providers, thereby increasing healthcare outcomes for Black and Brown patients. Studies show that the more providers look like their patients, the patients have better outcomes. So that's my focus in terms of improving social EM initiatives. I'm also very passionate about increasing health literacy and awareness through social media. And so that's one of many platforms that I use to be able to spread the word regarding, as I mentioned, health literacy. So I'll speak more about what I do as the session goes on.
Hi, everyone. I'm Joyce David. I'm working at South Shore University Hospital out in Bay Shore, Long Island. And I'm the director of social EM here and also the director of PI and quality. I got involved with social EM, as a child of immigrants and also a New York City kid. You can't help but observe what's going on around you and the inequity, and sort of got involved just by observing what's going on around and within my own family. And then I went into social EM a little bit more, social medicine through Sophie Davis School of Biomedical Education, which focused on increasing underserved communities and services to underserved communities, and also increasing underrepresented minorities in medicine. So that program really drove my passion for serving in communities of need and for also increasing equity in healthcare. Here at Bay Shore, people think Long Island is privileged, but it's very, very diverse in its socioeconomic status, and our community is very diverse in terms of economics and in terms of ethnicities and language. So our focus is really to increase equity, health literacy, and education in the community. So we have a few programs, community outreach programs, health literacy programs. Our main goal is to partner with community programs already that are trusted in the community, and really partner with them to advance healthcare for our population. We're also actually, as Dr. Jameson also is focusing on, is increasing education and mentorship and sponsorship for our children in the community. I know that programs like Sophie Davis, programs like the Northwell Pipeline program, all have been really beneficial in increasing access to education and healthcare. And so that's really one of our focuses. And we're actually developing a program. Although Northwell has a program out in Hempstead, we're trying to develop one for Suffolk County right now. And we're going to be launching that, which is very exciting. So we are trying to address inequities in various manner throughout the hospital as well as in our community.
So I will jump in last. Hi, everyone. Thank you so much for having me. My name is Katrina, and I am actually a clinical social worker. So I am the non-physician on the panel who loves working with social medicine emergency room providers or emergency department providers. And so I do teaching at Columbia University for future social workers. We talk a lot about emergency medicine. We talk a lot about social medicine. We talk a lot about chronic disease management, how the health system operates, and different ways that we can look at, assisting people not only while they're within the health system, but helping to keep people out of the health system when and if all possible. And I like to say that my first interaction with social emergency medicine was actually my first job in the emergency room at 17, where I was an emergency room registrar, which meant I had to get the health insurance information from people while they were waiting to be seen with their broken bones or throwing up in a bucket, and really being exposed to what emergency room care looked like for people. And this was before the Affordable Care Act, before EMTALA was implemented, and what that meant to be able to make sure that we were treating people who came from different socioeconomic statuses to make sure they were getting equal level of care. I've done a lot of clinical work, and right now I do a lot of consulting with health departments, clinics, major medical institutions about how we improve access to care, create quality improvement initiatives, and improve social determinants of health.
Great. Thank you so much for that great introduction to what social EM is. We thought that would be the best way for everyone to get to really know, and we'll continue throughout the night. So I'm going to move on to the next question. So this question is, what does advocacy mean to you? And how have you witnessed advocacy benefit your patients or your clients? And just same thing, whoever wants to jump in.
I'll say something. Advocacy, what it means to me. So, in simple terms, for me, advocacy is basically giving a voice to the voiceless. As many other people on the panel mentioned, patients from underserved communities, one thing that they in general have in common is that they really do not have a lot of equity or leverage when it comes to advocating for themselves regarding their health needs, regarding health resources. And like I said before, a lot of that is because of just a lack of basic health literacy for many reasons. But at the very crux of the matter, that's kind of what I see it stem from. So in terms of advocacy, the question is, have I witnessed advocacy, how have I witnessed advocacy benefit my patients? And I mean, that's something that is almost like not even tangible. When it comes to advocacy in the emergency department, there are so many different opportunities. One, the first, I guess, or the biggest for me that comes to mind is when patients are brought in by EMS and by police. For those of you who are not aware, I did mention that I work at St. Barnabas Hospital, but I trained at Jacobi. And so I've been working in the South Bronx for the past 11 years. And the Bronx is one of the poorest, not just boroughs, but just like areas in the United States. And so we have a lot of patients with very detrimental health determinants, I would say, a lot of psych issues, as we all know, like I said, very limited socioeconomic status. And so we have patients who are brought to the emergency room for many different reasons, who are brought in, like I said, by police, by EMS, as what we know as EDPs, emotionally disturbed people. In these situations, I find very often that you have a community who are unfairly targeted, I would say, by law enforcement, and are brought into the emergency department as a means to an end. So I'm trying not to get into too many specific details, but you'll have patients who come in for various issues that are mostly related to socioeconomic status, whether it be living in a shelter or addiction issues, whatever the case is. And there are many times that they're brought into our emergency department with the expectation that we're basically going to just like sedate them and wash our hands clean of them. In terms of advocacy, one of the things that I do that I find that's very, very valuable is to actually speak to patients and actually listen to them and understand the circumstances that might have brought them to the point that they are now, that they come in handcuffs or come in, with a label, like I said, as an emotionally disturbed person, and really try to understand culturally, as well as just like as a human being, what it is that they're actually dealing with. And I find that with actually speaking with them and really listening to them and understanding and being able to put certain situations in cultural context, I'm able to, get them out of trouble, so to speak, with the police. I'm able to avoid them having to unnecessarily be medicated in our emergency department, unnecessarily be seen by psychiatry for, which could take a psychiatry evaluation in an emergency room as busy as mine could take 2 to 3 to 4 days, right? So keeping them from having to miss out on jobs and work and childcare for unnecessary reasons, mostly because of like miscommunications. So in terms of advocacy, a long answer now being made short is really, like I said, through listening to my patients and really understanding what they're dealing with and putting it in context to be able to help them as best as I can.
So I guess I can pitch in and sort of follow off of Dr. Jameson there, because I was thinking so much about what you said. And, I worked, my focus is primarily HIV prevention, care, and treatment. And I used to be at Montefiore, so very familiar with the community that you serve. And also they share a disproportionate burden of HIV and Hep C infection as well. But so much of what you said that resonated with me is not only listening, but letting the patient guide you. right? So we can't refer people to something they don't want to go to. That's not advocating. So it's really meeting that person where they're at and seeing what they're interested in. And, as future physicians, get to know your social workers. Emergency rooms are the catch-all for patients, and social workers are the catch-all for when we don't know what to do with patients, right? So get to know your social worker. March is Social Work Month. Do something nice for your social workers in March. But you will find us being your educators, your resource providers. I used to call social workers Rolodexes that listen, but I don't think anybody really knows what a Rolodex is anymore or uses them. We will be your counselors. We will be cultural brokers. You guys will end up in hospitals all over the country. Normally, your social workers are going to come from the communities, from the people you serve. So use them in order to be considered a trusted and valuable resources. And thinking about, you're going to meet us if there's a complicated patient, either in discharge planning or an admission for someone who might be there for a mental health or substance use emergency. And thinking about how we can collaborate, because working together, you're going to have much better outcomes for the patients than if you try to do this alone. So I think advocacy benefits our patients when we're able to work in partnership, when we're able to connect people to things they need. And most importantly, how do we keep them from coming back? And I think that doctors and social workers can work really collaboratively to keep the ER from becoming a primary care home for people.
I wanted to just piggyback off of what our other two speakers said, that, along with advocacy comes allyship. And as physicians, you hold a lot of power, that like MD, DO, that comes with a lot of power. And you have to use that to the benefit of the patient. So like Dr. Jameson was saying, when patients come in with police, I usually ask them to step out so I can speak to the patient privately. Like, every patient's allowed privacy, right? But a lot of times it's EMS or police telling us the story of what's going on. And that's what triage writes, that's what's documented, and it's not the patient's story, it's not the patient's voice. And our job is to be the voice for the patient. And so part of that for me is advocating for the patient is using the power we have as physicians to, like Dr. Jameson said, to really listen to them and to address their needs. I was writing some points down, and Katrina completely hit it on the head. It's interdepartmental, it's interprofessional. We can't do everything. And I love our social work department. I've never worked with such great social workers before, but they really are a Rolodex of information. But a lot of social EM is focused on the fact that we're not just dealing with acute care and critical care anymore. We, for better or worse, we are the safety net for society, and we have to kind of own it. And part of owning it is focusing on public and population health, and looking at it from a more ecologic perspective, that healthcare is not just the disease process. It's not just a cholecystitis. It's like, oh, this patient does not have care. And so if I send my undocumented patient with biliary colic out, and then he comes 3 times, he's never going to get an elective chole, right? So my job is to tell the surgeon, hey, he's never going to come see you. Why don't you just take this gallbladder out now before he becomes septic? So part of our job is, maybe it's not clinically indicated right now, but we have to take the whole global perspective into the picture. What is the patient's resources? What is the patient's insurance? What is the patient's language? Do they understand what's going on and the consequences of their, being able to follow up? So taking all that together is really important. So in terms of witnessing advocacy, in my community, we have a lot of undocumented patients who really need advocacy. And language justice. And so that's really where we see, where we do our work really in our community. And even if it's like a warm handoff, like using my interpreter to make an appointment for the patient before they leave, those are like small ways that are very impactful to get patients on the right path, where they are having a warm handoff to get that link, and they won't miss it now because we've enabled them to just take that next step, and we're guiding them there, you know, and giving them the resources. So that's really what, you know, advocacy and allyship for me is, just speaking up for the patient.
I just wanted to follow up on some of the sentiments that you guys mentioned. Hi, I'm a fourth year med student. I'm just wondering, do you guys feel that overall that there are enough resources and structures in place that you feel like, you know, there's enough you can do to advocate for your patients, or are there certain situations or types of patients where you experience a lot more roadblocks?
This might come in a little later, but in general, in terms of obstacles, yes, oftentimes there is a lot of lack of funding, especially in our city here. Sometimes it's lack of funding, sometimes it's lack of investment in and understanding of social issues by administrators. Sometimes it's inertia and fatigue and exhaustion faced by providers themselves, who are often working in a system which is designed to extract as much labor from them at the lowest possible cost and compensation. You know, in general, there is inequity of care for patients that are not going to benefit the system as much financially.
Thank you all so much for such robust answers to this. It was so helpful to hear that from your perspective. That leads really well into our next question, which is that, as we all know, the emergency department is known for very brief interactions. So what are some tips, or what are some ways to maximize the potential for advocating for our patients?
I can jump in again. I think a lot of our most effective and thoughtful advocacy will happen outside of the emergency department, and outside of shifts, because we're so busy during the shift. But within the shift, advocating for patients in the emergency department means discussing with consultants and admitting services when we feel that patients are not safe to go home. It means providing culturally and language appropriate care and discharge instructions so that patients can be empowered to care about their own health, and so that we can set them up for success at home. It means asking patients about how they will get home and arrive to their follow-up visit and get adequate food and water. And we should also ask whether they feel safe at home or if anyone's hurting them, so that we can connect them with our available social services appropriately.
I would say the challenge of doing some of these social screenings is that if you're doing a screening, you need to be able to intervene and not just identify the issue. Obviously, that's a first step. And I think a lot of times in a resource deficient environment, as our other speakers have identified, it's tough because we might not have all the resources. And I think we'll probably get into this a little later when we're talking about developing a program, but part of, you know, social EM is like gathering the resources, and there's so much out in the community we don't know about, but obviously there's still lack. But find the resources is step one. At our hospital, we've created a community resource booklet and then we've divided it into different populations that might need help, like undocumented or Spanish speaking resources. I think that is helpful. And I heard Adrienne say that they're working on developing a social EM screening tool, which is so helpful because we can't help people if we can't identify them. So those are kind of like the first steps, I think. And we're also trying to develop that here at South Shore. It's tough to get screenings because everyone's sick of, you know, usually it's our nurses doing it, right? So they're like already asking about food insecurity and domestic violence and human trafficking and so many different things, and we're adding to their burden in addition to them having to draw labs, do meds, everything else. So trying to find ways to do this in an efficient way are things that we're looking towards as well.
So I would say you don't have to have all the answers, but some of the best way to do these brief interactions and maximizing the potential for it, I think two things is one, making it doesn't have to be the only interaction. If we're able to connect people to follow-up care, if you're able to connect someone to a social worker, it can actually create sort of this chain of events where you can get people connected to longer interventions. And I think, and I don't know if there's anybody here who has any interest in psychiatry, psychology, things like that, and thinking about social medicine as well. But when someone's in the ER, they're sick, they're vulnerable, they don't feel good, there's a motivation for change. So, and we talk about this, I think we'll talk about this a little bit later, but when you have someone, especially in something that New York Health and Hospitals is doing for someone who has a non-fatal overdose, meeting with the peer recovery coach before they leave the emergency room, right? And sort of trying to capitalize on that moment that people are ready to make a change in their life. So you can be brief but impactful as long as you're connecting people to other aftercare services. And once again, use your social workers.
I don't have a long answer just because everybody kind of hit most of the major points, but just as an aside, I am a physician who only works night shifts. And so as a nocturnist, advocacy looks much different than it does during the day. I love that we have Katrina representing all of our social workers on the panel. For me, or as far as I'm concerned, social work like almost doesn't exist just because we don't have social workers overnight, right? And so there are certain situations, like I said, working during the night shift, where your resources may be even more limited in an already limited area. And so one of the ways that I kind of try to maximize advocating for my patients, even during times when, I don't have full complement of what the hospital offers, is really just knowing the right questions to ask to be able to hit a lot of, as Adrian already mentioned, like certain screening points and elicit certain information that is very important, right? I manage residents, and I'll see some people, some of the residents might say, oh, this person's ready to go. And I'm like, okay, well, where are they going? Oh, they said they live on such and such, block or whatever. And I'll find out with conversing with them that they asked, well, are you homeless, right? This is a question that would put certain people on the defense, right? So like, yes, you got the information that you or you may not get the information that you need to because of the way you ask certain questions, right? So as opposed to, hey, are you homeless, right? That's something that can be considered offensive, for lack of a better phrase. The question you would want to ask is, where do you live, right? Like that puts it in a completely different, non-judgmental, non-labeling, if you will, way of asking things. So like I said, overnight, where I don't necessarily have certain resources, I like to ask questions in a way that I can actually get a real sense of what my patient might be going through, particularly, like I said, at night, where you have patients who are coming there, who are dealing with who are undomiciled, for example, or, are dealing with food insecurity. The emergency room, especially at night, like I said, turns into like a completely different arena as far as I'm concerned. And so just being able to really be sensitive to what a patient might really be there for is very much so helpful. And like Katrina also said, just knowing like how to refer them after you get that information is also very, very important.
Thank you for all those perspectives. We're going to move on to your next question. In your experience, what are some social issues that should be prioritized in New York emergency departments? Have you faced any obstacles while trying to mitigate these social issues? So this is kind of similar to what the other student brought up earlier, but if you wanted to elaborate.
I can jump in. Some more things I think about are language and translation services, adequate staffing ratios, outpatient clinic, urgent availability, availability of referral to accessible specialty services, making sure patients can pay for their medications, making sure patients have access to adequate food and water, making sure there are adequate and humane and modern maternal health services available, making sure that the social work and care management department is empowered to connect patients in the to proper social services, and able to follow up on and evaluate how effective their referral was. Better interactions with law enforcement is something else that was mentioned here earlier. And then also creating protocols for drug use replacement and harm reduction, which was also mentioned.
Also, piggyback on that, I think staffing, although it doesn't seem like it would be the biggest issue, in my mind, that's something that absolutely should be prioritized. I would say every hospital that I've ever worked in my 11-year career so far has been understaffed. And the ramifications of that are innumerable, honestly. It not only affects how we can take care of patients, but the level of care that the patients are able to receive, and honestly, whether or not we're able to really care for them properly. It's flu season right now. Our emergency rooms are bustling right now, I'm sure, with lots of patients who are admitted. There are no beds for them to go to. The nursing ratios are almost unsafe, right? And so bringing patients in to an environment where they're there for care, and then not even having the staffing to even really address the medical issues, let alone their social issues, their economic issues, I think is one of the biggest issues. So yes, everything that Adrian just mentioned are one of like are many problems. But like I said, if I had to prioritize one of those issues, it would be the staffing, which I guess is a little nuanced in comparison to everything else that our patients are dealing with. But it absolutely is, like I said, detrimental, or rather very critical to how we take care of our patients.
Thank you, Dr. Jamison. I feel like that perspective is something that students wouldn't be thinking about yet, but I think it's a great thing to get everyone to start thinking about if they are considering working in the emergency room or pursuing any kind of social EM fellowship like that. I had a follow-up question just about a specific social issue. A few of you have mentioned like increasing language access in the ER, and I am a fourth-year medical student, and so during my third-year rotations, a lot of my experiences in the ER with language access, a lot of the times like the iPads or the phones that they would use to do the interpretation might just like not work. And so I wanted to know, like, what other ways could we improve language access, whether it be like, do hospitals nowadays hire in-person interpreters, or do they compensate and like for the certification, like provide the certification for bilingual doctors, or provide extra compensation for bilingual doctors if they're playing both of those roles? Just wanted to explore that a little bit more.
Up until recently, we had pretty abysmal Haitian Creole translation services. They were only available 12 hours a day by phone. It was hit or miss. And then a few of our residents advocated to city officials, actually, just given the amount of Haitian Creole patients that we serve, not only in the emergency department, but also in other specialties. And, you know, they fought so hard for it that they actually did hire a bunch of in-person Haitian Creole translators and provided us with 24-hour Haitian Creole translation services, which is something that we did not have before. So that was a direct result of advocacy. I would say inpatient translations or in-person translation is obviously better, but it is expensive. But at the very minimum, there needs to be 24-hour translation of you know, most of the major languages, in addition to translation of discharge instructions, which is also very important. And a lot of hospitals don't have, you know, adequate you know, availability of either of those things. So I think that's a good place to start. Even having, you know, the virtual translation available and good discharge instructions, you know, really goes a long way.
piggyback on that. So, under the Affordable Care Act, any organization that accepts federal dollars, which includes Medicare and Medicaid, are required legally to provide translation services in major languages for their patients. That being said, we often rely on family members, environmental services, people from other professions, and we shouldn't be doing that. I know we do that in a pinch, but it's not good clinical practice, and it can even be illegal. And we risk medical errors because while someone may speak a second language, or even if that second language is their first language, we're talking also about health literacy in someone's secondary language. And we can't put the onus on certain people who may not have that special medical vocabulary. So when we're thinking about that, even if you're a bilingual doctor, make sure that you're really comfortable, or look at some other sort of certification to make sure that you have all of the medical vocabulary that you need as well, and not just sort of the general linguistic services.
Thank you so much for that valuable perspective. We did have one more question for the advocacy portion, but we do want to make sure that we have some time to talk about the social EM fellowship a bit more. So Claudia, if you don't mind just skipping to part 2, what is social emergency medicine? So our first question here is, what are some unique aspects about the social EM fellowship that make it different from others?
One quick thing that I could say is that social EM cuts across a lot of the EM subspecialties and is applicable to other fellowships and other subspecialties, such as global emergency medicine, ultrasound, health administration, health policy, etc. So there could be a lot of synergy with people who are subspecializing or have found niches in other parts of emergency medicine, because truthfully, this matters to all emergency medicine providers. So you can find some common ground no matter what other people are interested in: research, medical education, etc. It cuts across all of those, and you can find some synergy.
If no one else has anything to add for this question, we can move on to the next. So this one was more about if you don't have a social EM like initiative or department already. So we were just wondering, what kind of funding or support do you receive from the ED or / the hospital to pursue social EM initiatives? And how does an initiative get started?
So I can talk a little bit about that from our department, because we're kind of in our infancy as a residency, and also we just started our social EM department 1 or 2 years ago. And so, it's really about what you're passionate about. And so I was seeing injustice in the department, and I was seeing injustice for our patients. And so that sort of just pushed me to go to my chair and be like, hey, what are we going to do about this? And then he's like, all right, this will be your job. So if you're passionate about something, that's what you should lead off with. And so for me, it was starting some discussion forums on what it means to advocate for patients, what it means to treat certain populations, and what are their specific health needs, and doing just like little tidbits, whether it was like just little social media slides, educating our staff on the specific needs of certain patients, how to approach certain patients, and being sensitive to their needs, what is okay and what is not okay, and what is completely unacceptable. and then we just opened up to have dialogue. So that's sort of how we started. And I would say if you don't have any social EM initiatives at your institution, start with what you're passionate about. Another thing that I'm passionate about is vulnerable women and children. And so human trafficking, labor trafficking is something that I'm really passionate about. And it is a big issue in Long Island with labor trafficking. And so that's something else that we sort of pushed in our department to do screenings and to do education on awareness on those issues. So I think if you don't have anything, start with the things that you see are issues in the department and start off with that and create educational platforms, open forums. You're never gonna, force someone to think like you, but you can create open dialogue and opportunities for education and just communication. And I think that's sort of where we started in our department, and we're sort of building up from that. And I am very lucky to have extremely supportive chair and vice chair who are great sponsors and mentors who, when I had my chair, when I asked about a situation, he's like, oh, you were targeted because you're a woman. And like, I didn't even realize it's sexism, but like, so having allies like that, or if someone's, targeting someone because of racism, and then so, your leadership, acknowledges that is so important to have that support. And I think sort of that's where we came from the ground up. I think we're very fortunate because Northwell is very supportive of social programs and has some means to do it. Obviously, university hospitals have more funding than community hospitals. I worked in the community level for 7 to 8 years, and it's just, it's the funding and the resources are very limited in community hospitals, but networking is really how we get that done, and tapping into the community. Communities don't always trust healthcare, so it's really important that we partner with trusted organizations so that we can gain people's trust, and that's sort of where we are working from the ground up. So that's what I would say in terms of starting up something.
I guess if I were to put on my former hospital administrator hat, I think what Dr. David said about who your chair is very important, but sometimes you have to do the support in order to get to the funding. This isn't something that a lot of institutions are generally going to throw money at. If you look at the clinics in your hospital which serve your commercially insured patients, they're going to look very different from your clinics that serve predominantly Medicare and Medicaid patients. So, but you all have a lot of social capital and thinking what it means to organize. So sometimes the initiatives get started just from the community organizing, from people, from seeing what you see. And because you have the ability to be connected more and less reserved from some of this administrative paperwork that you kind of get as you get more into the upper layers, you can coordinate and find initiatives and tie it to causes. And then if you're able to make sort of these social determinants of health or medical economics, we may be saving the hospital money down the line by focusing on this social issue, right? And a lot of times if you can bring that in, that will work even in a community hospital. And as you get into later in the field, if you can get your K grants and your R01s and all of those kind of things, then you can actually get money from the federal government to sort of play in this field of social emergency medicine and what interventions could look like.
I also just wanted to echo something that Joyce said. She mentioned passion. And one of the things that I love about social emergency medicine is that it touches so many different aspects of a person's age, race, culture, gender, sexual orientation. Like there's so many different avenues that you can take when it comes to social emergency medicine. So really, in terms of starting an initiative, it really just takes you being passionate about any aspect of social emergency medicine, honestly, and being able to take the first step to get it done. There are a lot of department heads and departments where where someone is needed in order to like actually care and steward certain initiatives. And so being that person who can step in and say, hey, like, I'm actually really interested in it. It's something that I'd like to spearhead. I don't think you'll meet a lot of resistance. Of course, funding And monetary support is always something that comes into play. And there are lots of resources, lots of grants, lots of there is a lot of money available. It's just a matter of like going ahead and like, you know, looking into it. But in terms of getting the initiative started, to be honest, it all it takes is an idea and somebody who's passionate about doing whatever it is that they'd like to see. So it's just really encouraging you all that medicine does not have to you don't have to be in a box when it comes to medicine. That's one thing that I love, especially about emergency medicine, is that it really does allow you to explore your passions within medicine outside of just being a physician, if that makes sense, right? So we talked about pipeline programs, for example. That has nothing to do with treating patients directly, right? But in the long run, you are helping to better take care of your patients without necessarily knowing or giving a certain type of medication or treatment, right? This is a way that you can express yourself, who you are, what you're passionate about within medicine. And like I said, without necessarily having to do so by directly touching or being at the bedside, if that makes sense.
Definitely. And I would say same as was mentioned, just to piggyback. So for us, the way that we get social EM initiatives in the hospital are twofold. So either it's top-down initiatives because the hospital realizes through their own research that there's a cost or financial lever that they've been missing, and that they're literally losing money because of not addressing social needs. So in that case, it's totally funded and driven by hospital leadership, and providers support those initiatives and push for them to be equitable and sustainable. And then the other way that social EM initiatives get done is grassroots and resident or provider-led. So we can do our own needs assessment, design the program or intervention, execute a low or no cost or self-funded pilot, show that the results are effective and efficient, and then advocate for this initiative to get institutionalized and adopted and owned by the hospital moving forward, so that it's no longer held together with popsicle sticks and glue and duct tape.
And just to add, I know Katrina was talking about, you know, hospital leadership, and it's probably like a little higher level than you would be thinking as a student now. But when you think about like an administrative perspective, studies on social EM have found that interventions and focusing on social aspects have decreased ED crowding, ED length of stay, ED recidivism, unburdening the physician, and like burnout is a huge thing, right? And if we can decrease recidivism and social issues, that actually is going to benefit the hospital. So unfortunately, like part of healthcare is a business, and sometimes the C-suite or those people in charge care about those things. And so speaking their language too helps to get that funding.
Thank you all so much for your honesty. I feel like you're giving me a lot to think about for my future. It's really helpful to hear from all of you. We'll move on to our next question, which will be our last pre-made question, but then we'll open up questions from the audience. Our next question is, what advice would you give to students evaluating residency programs for how well they support social EM and health justice initiatives now?
I would say ask what they're doing to keep patients from coming to the emergency department unnecessarily, and how and why they connect patients with social services, and then listen to see if their response is more human-oriented or money-oriented, or, you know, hospital administration says this and we do this.
Agreed. I'd also say the proof is in the pudding, right? So if you're shopping for an institution that values social emergency medicine and health justice initiatives, seeing that they already exist before you get there is very, very important, right? It's the same thing when it comes to diversity, for example. Being able to see whether or not it's actually important to a program should be evident by who is in that program already, right? That you shouldn't be the pioneer of the initiative or of the diversity, for example. So like I said, just seeing that it already exists and it's something that you potentially could build on is very telling in and of itself.
I think also, you know, when we first started, we sort of had a, hey, these are things you can opt into. And then we've slowly gone into, this is part of our curriculum. And So every month we have core subject blocks. And so for each core subject block, we also focus on one social aspect of that subject block, whether it's in palm or GI, cardiology will focus on some sort of social EM aspect. So seeing if, like, you know, it's still a burgeoning field, but seeing if they're really incorporating social EM into the residency curriculum is another telling sign of whether they value social emergency medicine.
Thank you all so much. This has been such an amazing panel. And now we'll open up for questions from the audience if anyone has anything on their mind.
Sorry, really quick. I just wanted to direct everyone to this page, and then we'll open up the audience because I didn't want to forget this at the end. We just added a few resources at the end of this PowerPoint that I can send out to everyone. But this was, EMRA has a list of all the social EM fellowships that are currently going on in the country. And then these other two links are just like getting to know more about what social EM is. But yeah, if anybody has any questions, feel free to unmute, or we can read from the chat. I do have one question. So in my search of like different residencies, what you had all talked about earlier about seeing if the websites or the residencies had social EM initiatives already, sometimes I just noticed that they might not list it on the website, or there's no section for it on the website, but then through word of mouth, I've heard, oh, they do that thing, or they do have that initiative. Do you have any advice for how students can go about that to learn more? Like, should we be maybe cold emailing the programs or reaching out to the residents if we're really interested?
I think getting a resident perspective is great, because it's usually going to be honest, and they're in it. They're like drenched in the residency, and so they will have probably the most clear, you know, vision of like what your life will look like there. So I think like when they have those dinners or those chat sessions, definitely join in. Even though they're informal, I think you can gain a lot of knowledge in going to those things, you know, just outside of social EM, just when you're doing your residency interviews. I think there's a lot of value in talking to the residents.
I think social emergency medicine is practiced on a spectrum. I think all emergency medicine providers practice it in one way or another. Some practice it with, you know, at the bedside, you know, through the questions that they ask, and being thoughtful, you know, about how their patients are going to do outside of the hospital, you know, ranging to a, you know, complete and robust social emergency medicine fellowship and program and division at the hospital. But I think there's something to be said about even if there's not, you know, a huge established program with a lot of support, you know, you could be somebody who goes to a place where this is not being talked about a lot, or you know, there's not a lot of communication around these things. It's not part of the graduate medical education, and you can be that, you know, advocating voice, and you know, bring awareness to some issues that, you know, that your patients are facing, and make an impact in that way. And, you know, arguably you can go to a place and make a bigger impact when there's not social emergency medicine infrastructure established, compared to where there is, you know. And obviously if you have more support, you can get different things done. But I think it's just a matter of what your perspective is, and, you know, how much heavy lifting you want to do yourself, and, you know, how isolated or supportive you're comfortable being. You know, but I think you could bring social EM awareness to wherever you go.
And just before we end, we just wanted to ask if any of the panelists have any last minute thoughts you wanted to tell the audience? And it doesn't seem like we have any other questions, so we can close out after that.
Thank you for inviting South Shore EM to this. I'm really encouraged to see all of you students so passionate about social EM and dedicating an hour out of your super busy schedule, likely between studying and everything. So it's really encouraging to see that the future of social EM is bright and energetic. And if you guys have any questions about South Shore or Bayshore EM, you're free to email me. My email is jdavid1@northwell.edu. But again, thank you so much. It's really encouraging also to meet Dr. Jameson and Adrian and Katrina, and to hear all their ideas as well. And it's idea sharing in social EM is, like what's really going to advance us. So I'm really excited.
I'd also like to just say thank you for inviting me to be here. I think it's wonderful that there are med students like yourselves who are so passionate and eager to know about something so early in your career. I think it's just so encouraging to see that you all care about this before you even get into it. So kudos to you all. Continue to seek and search information regarding all of this. I also have to plug my program, the Summer Enrichment and Mentorship Program. We just started our application cycle for our 4th cohort. I'm very excited about it. As a matter of fact, Rebka and Yoeli, who's also on the call, both participated in the program as well. And so I just wanted to put that link there for anybody who might be interested. It's a 6-week course for first-year medical students who are underrepresented minorities in medicine. We're going to give you a very early exposure to emergency medicine, to clinical medicine, learning how to do suturing, ultrasound, different procedure workshops, as well as mentorship. And then, of course, lots of shadowing in the emergency department. So please, if you're interested, if you're able to, just take a look at the website, the application, and share it with those of your friends and classmates who may not be here to be able to get info on it.
I just want to say thank you so much for inviting me to join you, and thank you so much for your passion and commitment. Please always think about collaborating in your interdisciplinary partnerships and how you partner with your nurses and your medical assistants and your social workers and your environmental services staff, because everybody is really going to touch the patient in a different way. So social medicine really means wraparound care. And as a professor, knowing it's getting to the end of the semester, please take care of you. If you have nothing left, you are not going to be a very good caregiver for others. So please try to sleep when you can. Please try to not eat all junk food. Look both ways before crossing the street. You're going to be tired. You're going to be exhausted. Go for the Uber, go for the takeaway, and, worry about catching up on everything else when January gets here. So take care of you so that you can take care of other people.
Thank you all. Thanks for having us. Nice to meet you all.
Thank you so much to our panelists for coming together tonight, giving us their time to be in conversation with us. We really appreciate it. All the tips and perspectives were really great and honestly very helpful. I really appreciated all the tangible guidance that you all provided. I just wanted to wrap up by saying that you can follow us for more events on our Instagram and Twitter right here. We are having our critical care and our VSLO events coming up after the new year. Happy holidays and take care. Thank you, everyone.
Bye, everyone.